One question that always comes up is, and this is open to anybody who wants to take this, is about nephrectomy. And Dr. Steinman, I'll give you 2 minutes to answer that first, and then we can have other people. So when would you send a patient with PKD for nephrectomy?
When do you do a nephrectomy? Specifically, not for pain, unless the patient's at end-stage renal disease, facing dialysis now or on dialysis, and you're not achieving pain relief whatsoever, then one can do a nephrectomy. But I do believe that you can do many things more. The algorithm of approaches I mentioned can address pain without causing a tremendous loss of kidney function, kidney mass, and kidney function. So nephrectomy almost never has a role. One thing I wanted to mention, when I shared that video, of the multiple bubble wraps of the cyst, how many average cysts exist in a patient, an adult patient with polycystic kidney disease? 23,000. That was done, a magnificent study done by Jared Grantham's grandson. And he wrote an article called The Tip of the Iceberg. For every cyst that we can detect with MRI down to a sensitivity of about 0.9 centimeters, 0.9 millimeters, 9 millimeters, that's about the degree of sensitivity. His grandson then took kidneys that were coming after with nephrectomy, after he did the MRI, and he did sections of the slices and counted the number of cysts. And for every cyst that we see radiologically, there are 63 cysts present below the level of radiological detection. So it's 63 to 1. So every cyst that you see on MRI, and that is all the studies, every study refers to Vince's original slides, there are 63 cysts that are below the level of detection. If you did the calculation, it comes to about 23,000 cysts per average individual. That's why you never go in and start taking the roof off cysts. You could be there for the rest of your life doing it. So I don't do nephrectomy unless patients are at end-stage renal disease. We did do it for a patient with intractable bleeding.
Right.
The bleeding would not stop. That was but several people who've had severe bleeding. We've done something, we've given DDAVP, and we've stopped bleeding in 2 out of 3 patients who had intractable bleeding. But that's a different point.
And anybody else would like to comment on nephrectomies, or when would they?
We published a trial at Mayo and looked at the experience. Each center, in general, it depends kind of on the center and the preferences. But there are some situations where it really is a win-win. If you've got a good surgeon and you've got a patient that's highly symptomatic with very large kidneys that are burdensome to them, causing mass effects, and they feel that weight there all the time. But at our center, we mostly try to wait until after the kidney transplant. And our surgeons like them to wait a year or so, and usually then they can take them out with a hand-assisted nephrectomy by pulverizing and taking out with one hand, chopping it up, and removing the organ. Occasionally, we have to do a nephrectomy before a kidney transplant. Now, we try to wait until that patient has advanced kidney disease and are just about to go to transplant, and usually that puts them on dialysis. So we usually have the donor waiting. So usually at our center, over 2/3 of our transplants, our transplant recipients usually have a living donor available, and so we kind of get them through that period if they're highly symptomatic. To give you an example, I had a patient, a young man in his 40s, who had advanced kidney disease and just started getting a lot of infections and pyelo in the native PKD kidney. And so at that point, we had him seen by the surgeons, and they opted to take out the problematic kidney, which then put that patient with stage 4 kidney disease on dialysis. But everything was staged. He had his donor waiting. Now, in the post-transplant period, the patient, it's a completely different situation. The patient is on immunosuppression, and so if they're getting infections, which are problematic and difficult to clear up, the balance of things may tip towards doing the nephrectomy. Other situations would be persistent hematuria, or pain, or hemorrhage, and then the balance tips over, favors removing that organ. The natural course of that kidney post-transplant, if you're on mTOR or calcineurin inhibitors, usually is that, and mTOR inhibitors, is those kidneys will shrink. But for some people, that's just not enough. Those kidneys are large, burdensome, and causing a lot of symptoms. And the patients come back to you afterwards and say it was a great thing they did that they had that kidney removed because it was just causing too much problems.
Great. I think that's, so the quality of life is important, and the indications are, as you mentioned, one is, and I just sent a patient recently for, not that many patients I sent for nephrectomy, but I did. And the reason was exactly the first thing that you said, is the burden of the kidneys and the size. And this was about 4 feet 10 inches tall lady, and the surgeon came out holding the kidneys like this. I mean, those kidneys were humongous. And she isn't so, I mean, she's a different person now. She's on dialysis. So that would be one. And the other one is intractable infections, hemorrhage, and pain, not so much. Like I agree with you, Dr. Simon, that they are a very, and I'll come back to the pain because there's some unanswered question that we couldn't answer.
Nothing is better than good judgment.
Yes, that's always the case.
Lifestyle is a big thing, especially in Southern California, but people come in and they're very physically active. They may be quite thin, and these kidneys are burdensome. They can't bend down, especially if they have big liver too. But it may be a situation that it's really limiting their physical activity.
Oh, absolutely.
And so you have to gauge that.
Yeah. No, I think that does have a significant role in quality of life, and also the kidney size tends to, you mentioned they think once they get transplanted, they can get smaller, but not. Because that's the other question that gets asked is, do they keep on growing, right? And we have seen that.
One reason that post-transplant with a good functioning kidney, blood flow to your native kidneys goes down. When your blood flow goes down, that's why kidneys don't increase in size much after successful transplantation. And it's a decreased renal blood flow that makes it easier to do the nephrectomy post-transplant if you need it from a clinical symptom standpoint. As you all know, we don't take kidneys out routinely post-transplant or pre-transplant unless there's a specific clinical indication for such.
And the other point that was mentioned was the surgeons. It's important to get a good surgeon. Keep in mind, and there have been some complications during nephrectomies, and there's portal hypertension that happens. We discussed that as well.
I haven't met a surgeon who called himself a bad surgeon yet, but.
There's a movement in our sector to offer nephrectomy simultaneously at kidney transplant. We're wary of this approach in our side of the field. That's a very large surgery, and for those of you that manage patients post-operatively after nephrectomy, especially big, huge polycystic kidneys, those patients bleed a lot. They become immediately hyperkalemic. Once you render a patient anephric, you'll be dealing with a potassium of 8, and it'll be in the evening because they've been in the operating room all day, and you'll have to dialyze them. So ideally, to avoid the bilateral nephrectomy, rendering a patient anephric if you can, but our surgeon pre-transplant, at the time of transplant, one of our surgeons is interested in doing a simultaneous nephrectomy, but that is kind of a pioneering approach, and the dogma in our center is really to just go ahead with the kidney transplant, and unless there's no space to put in the new kidney, to leave the natives in there unless there's one of these other indications.
That idea to remove kidneys, I'll say it point blank, at the time of surgery, because it increases the surgical time, increases your anesthesia time too long, and that you don't want to put the new kidney at risk with prolonged anesthesia for something that, let's try this. That puts the patient at risk. That's poor judgment from my standpoint, just in case you didn't think I had an opinion.
All right. Excellent. So quality of life surgeon. Some questions, I think this is for you, Dr. Steinman. You mentioned decortication, you mentioned fenestrations. during your surgical or procedural. They're asking what's the difference, and also what are you injecting them with? We never answered that question.
Right.
The injection, when you do cyst aspiration, you inject.
I'll start with the last one first. It's not a cyst. When I actually puncture a cyst, I put in saline, and see if you expand that cyst with a few cc of saline and reproduce their pain. They say that reproduces my pain. Then at least you're in the right cyst for that's causing the patient's discomfort. I say, and that comes when we've done all of our skin markers and we're not too sure, etc., because of the kidneys. So we've done that on occasion. It's something wonderful in your hip pocket to utilize when your judgment says, is that the cause for the pain? So that's when I never aspirate a cyst. The only time we've ever aspirated a cyst is liver cysts with infection. That's an indication to go aspirate and obviously drain the cyst specifically before that. Then as far as unroofing, decortication, unroofing, same. The liver fenestration is when you actually do partial hepatectomy through the right and left linear of the line. But it's decortication, removing the roof of the cyst is the procedure we're doing for pain relief. Did you like that video? That was, I work very, I was in the OR with our laparoscopic urologist who's spectacular.
But you weren't doing the procedure yourself, were you?
Yeah.
You were doing the procedure?
No, he let me.
Okay.
He let me come in there like a medical student. I did the I did a little zapping, but he let me just what it feels like to move the scissors and the fingers. But that takes talent. When Murray said a talented surgeon, we have a guy, as are many other people, who are really talented with robotics and with the laparoscopic decortication. He's the only one in our place that I would let do it who does it, so.
Very good. So that's excellent. Next question. I think we have answered about cancer, kidney cancer in PKD patients.
I'll let many patients go.
I didn't even ask the question.
The very low incidence, well, we all deal with this, the very low incidence of kidney cancer in patients with polycystic kidney disease is reported, but it's reportable. So one doesn't do a nephrectomy for PKD. I really can count on the number of cases reported in the literature, mainly from Japan, interestingly enough, that report about the transformation to a renal cell carcinoma in patients with PKD. But it's a rare phenomena. Randy, you have as much experience.
I agree. It's a mystery why we don't have more cancer in polycystic kidneys, because when you look at the polycystic kidney, there is a lot of hyperplasia. So the cysts contain, especially end-stage kidneys, contains a lot of polyps, a lot of microscopic adenomas, a lot of multilayering of cells. So there is increased proliferation. Despite that, the progression to cancer is rare. So there is not clear why. It could be that there is a lot of proliferation, but there is a lot of apoptosis at the same time. So the apoptosis kind of balances the proliferation. Having said that, still it's controversial whether there is increased renal cell cancer in polycystic disease, but the truth is, if there is increase, it's really very minimal.
PKD is a tumor. It's just a benign tumor. It's not a malignant tumor. So all that cell proliferation with the same cell type, they don't develop aberrant cell lines. So the cell, you think of PKD as a tumor, it's proliferating. Just fortunately, it's benign.
Also, part of the controversy generated, if you look at some of the articles that have described increased renal cell cancer in mostly is done in pathology studies. And you look at the size of the cancers, many of them are millimeters. So, and the question is it really a cancer, or how you define a cancer?
In practice, we get a lot of people coming for consults for PKD, so we see a lot of imaging. I've had cases of kidney cancer that were missed in other places. So one needs to make sure the imaging looks good, especially in a patient that's having kidney pain. If you suspect cancer, you should use contrast enhancement of some sort, if feasible. That's a trade-off if the patient comes in and they have established chronic kidney disease stage 3 or 4. That gets difficult. There are specialized imaging that can look in more detail. There's this diffusion-weighted type of scan that can be done using MRI. In terms of management, if the patient has renal impairment, well, that's a problem, because if you're going to do some nephron reducing surgical intervention, and especially in a patient that's higher risk that has chronic kidney disease. And so we do a lot of cryoablation, and then we monitor, and our urologists monitor with us, and we have close follow-up, because the cancer can come back with following the ablation, and it has to be watched.
Great. I think just to summarize, the PKD is uncontrolled cell proliferation. That's what it is. And as you rightly said, it's the difference between cancer. It doesn't spread. I mean, but it is. There's a lot of similarity between tumor and PKD, and some of the drugs that are being used now or being tested in PKD patients are actually anti-cancer drugs. And one of them, as Dr. Arman discussed, is our TKI, tyrosine kinase inhibitors. But overall, whoever asked this question, the short answer is, as far as you know, and Dr. Torres put it very rightly, that there is no increased incidence that we know of kidney cancer, renal cell carcinoma in a PKD patient. The problem that I can see sometimes, and I think Dr. Hogan touched on it, is when we are doing ultrasounds and we do studies, and they report them as complex cysts. And what do we do with those complex cysts? I mean, that becomes, and you know, with these 23,000 cysts you're mentioning on top of each other, I think you rightly said that we need to get the right study then and give contrast and bite the bullet on that one as much as we want to avoid giving contrast. But those are challenges that we see clinically in which they show up as complex cysts and you don't know what to do with them.
And we'll comment on that. You can't, PET scan's no good for kidney cancer. You can't use.
I'm sorry?
PET scan's no good when you're looking at kidney cancer.
Right.
That's what our urologists tell us. It's not helpful.
Right.
We use the dictum, go slow at any speed. Practice kindergarten mathematics in your decision making. It's easier to add and subtract. Once I've done something, I can't take it away, but I can always do a little bit more. You always sit back and say, you know, go slowly. And if you sit tight and follow up with repeat imaging, if you have a concern, nothing is going to grow that rapidly if you can't detect in 6 months. And if you take a look at, it's difficult with a PKD patient, but using the Bosniak classification for cysts. And if you're very careful about the Bosniak classification, you get an idea that really determines who really is at risk for a malignancy in a kidney, in any kidney. And so you work with the urologist and the radiologist very carefully. And on all cysts we are evaluating, we look at the Bosniak classification. It's a very, very helpful tool to assess when to jump.
Right.
The whole time.
Yeah.
That's why I always did very poorly at poker.
But I think the problem, Dr. Simon, is that there's so many cysts on top of each other. It's very difficult to assess, and we are doing enough studies. You know, when the first thing is you do make sure that they don't have kidney cancer, but it is a slow-growing tumor. So in most of the cases,
that's why an MRI, if you really look, is really the only tool to use. It's too difficult with it. I think that an ultrasound is really detect.
Mm-hmm.
Now the new age ultrasonography equipment is getting very sophisticated. It's getting very close to MRI in terms of the sensitivity. But that's a major investment, and very few medical centers have the most up-to-date recent ultrasonic imaging that's very sophisticated. Most places don't have the capability.
Very good. Now, a question that was asked actually a few times, was about, so one was just testing children for ADPKD, and the other one was gene testing, but either way, in an asymptomatic child, and I'm making an assumption the child is 18 or younger, would you test?
When I check out, I've done one thing in life that I'm most proud of. A little bit of history. GINA, the Genetic Information Non-Discrimination Act. Representative Louise Slaughter from upstate New York, beginning in about the early 1990s, introduced this Genetic Information Non-Discrimination Act, saying that you could not discriminate against someone's genetic information in terms of employment or in terms of their health insurance, not life insurance. Every year for 13 years, it did not get out of committee. And it kept on dying because of, I'm going to say, Republican opposition. Because the insurance industry was is a major source for funding Republican candidates anyway. Fast forward, I took care of an individual whose father was a U.S. Senator, and she had no family history of PKD. I then pursued it, and I got the family, including the senator and his wife, etc., to get ultrasounds. And the senator turned out to have PKD, unbeknownst to him. And then I checked the whole family, and it was relatively widespread in many members of the family. I then had meetings with the family in Washington and discussed PKD implications, etc. And the senator was incredibly appreciative of my coming to Washington and meeting with the family. And he said to me, "Ted, what can I do for you?" And I said, "Senator, let me tell you what you can do for the country." I then described GINA to him. He was unaware of it, as many senators and representatives are not aware of all the bills that never come out of committee. I told him it was supported by the House overwhelmingly. Only 2 or 3 people in the House rejected it. One senator from Oklahoma, Tom Coburn, a gynecologist, was holding this bill up in committee, and one senator can block any bill from coming out. One of the things you learn. And it turns out that a large percentage of his income was coming from the insurance industry. So I said to him, the senator, "What can we do?" He said, "Tell you what, I'll call Nancy Pelosi, my dear friend, tomorrow to verify what you're saying because I can't have egg on my face." And he called Nancy, and he called me back and said, "Yes, what you said is absolutely, totally correct." If I approached Senator Coburn directly, he would be a mule, the heels would go in, and the answer is no. What we need to do, and he said, "I need to get my dearest friend on the other side of the aisle, Harry Reid," who was then the majority speaker in the Senate. Turns out that Harry Reid was the master of manipulation of getting things out. 2 weeks later, the bill came out of committee, came to the floor, passed 98 to 1 no and 1 abstention, and that 1 abstention came from Senator Coburn. 2 weeks later, it was on President Bush's desk in May of 2008, and I have one of the pens that was given to me when President Bush signed the legislation in place. So the Genetic Information Non-Discrimination Act that Trump is trying to overturn, but fortunately hasn't so far, says you cannot discriminate against genetic information, whether that be breast cancer, PKD, or any other genetic information in terms of employment or in terms of health insurance. But it doesn't affect, I say, life insurance yet. So at least that is the law of the land. Now, do I screen children? The answer is no, not at the current time, because of insurance, not for any other reason. You don't want to label someone who has insurance who then has a disease that may affect their life insurance. So I do not routinely screen children. I suggest that the families discuss it with their children when they are of an appropriate age, maybe when they're in high school or early adulthood, letting them know if that individual is then going to be in a significant relationship with a person. I think it's incumbent upon them to tell them about the inherited disorder in their family, and at that point in time, one can get an ultrasound, and I think you can still bury the information as long as you don't tell the patient directly, supposedly. So that is the only time I would routinely screen someone under 30, routinely. As you all know, and everyone sitting here will say, if you don't have any cysts, and you are a member of an affected family, obviously with PKD, if you do not have cysts by age 30, you're home free. None of us have seen cysts appear after age 30 that then develops into full-blown polycystic kidney disease if there's no cyst detected before age 30.
Yeah.
Sorry for the long-winded.
Very good. Thank you so much, Dr. Simon. Any other comments? Dr. Harris from you or Dr. Hogan?
I know what it's like to do a TED talk now. I think I think we see the same way as Ted, that we don't normally test children if they're asymptomatic, but we encourage blood pressure and other possible complications to be monitored, even from a young age, because we know that children become hypertensive quite often with ADPKD. I know there's some trials going on with tolvaptan at the moment in Europe in children, and I think depending on what happens there could be a change in whether children will be tested or whether there will be a higher incentive to test children for to see if they're affected. And obviously, if there are young children, probably genetic testing is going to be quite important, as imaging might be equivocal in some of these cases, although I think most patients with a truncating or fully inactivating PKD1 mutation will have multiple cysts by the early teenage years, for instance.
Yeah. Very good, and I think that's what our approach is at UCLA, is we tell them to monitor blood pressure, making sure that they have a healthy lifestyle, and hopefully they don't have a diagnosis, but they should keep in mind they might have a diagnosis. Just because they have not been tested does not mean that they don't have it. Yeah.
I would say I would agree with the conversation so far. I would add that this is a difficult issue, and hypertension is very easy to treat, and it's easy and should be screened. Children should be screened for it. The problem is, first of all, when people are coming to us, there already is a fair degree of concern and worry, especially they usually are aware of 2 generations in the family that have had mother and grandmother that died of something, and often the child or teenager is very worried about all of this. So that's an issue, and sometimes my role is to dispel all of that concern. Generally, we will focus on the blood pressure screening, have a good look at that, talk about healthy lifestyle, try and dispel the stress that comes around this possible diagnosis of a genetic disease. Just as last week with any genetic renal disease, the families are very well informed now, and they know that most of them can have insurability under their parents' plan until age 26. So that at the current time. But whether that will change, that's another unknown. So there's a lot to discuss here in the room about this. I think there are a lot of benefits to even just making the diagnosis. And then it was posed to me with another genetic renal disease the other day, and I said, yes, you're right. We have ways to anonymize the patient, and oftentimes I will not put a research genetic testing in the chart, and we don't have to discuss the clinical genetic testing. If it's done, it may not need necessarily to go in the chart. So there's sort of a way, it gets quite complicated. But we do get patients referred with the worry of this and their teenagers. are transitioning from adolescent into adult care, and so this is quite a common issue. And now that tolvaptan is approved, it creates all the more impetus to consider.
Very good.
I think we should, when we have an effective therapy, then I think it would be worthwhile to screen. Rather than exposing someone to a drug, or any drug, tolvaptan or anything else, from a young age on, bothers me, obviously, without any long-term track record about potential complications. I will have a comment, if you want further, of a different approach I would try, or have trying.
Do you want me to ask a
Yeah,
question?
what the hell? The magnificent work done by Vince and Arlene and colleagues about the role of the V2 receptor antagonist. Now I'm going to turn to Vince and quote his magnificent article quite a few years ago, not that many years ago, written with Lisa Banker and Jared Grantham, the title of which was, "It's the Water, Stupid." And so I quote a colleague, and then I quote the other article by Vince and Peter, looking at crossing the Brattleboro rat, the role model for diabetes insipidus because of the absence of vasopressin, with the PKD rat. And what Vince very beautifully showed here, that the cross between the Brattleboro rat and the PKD rat resulted in no cyst developing in the rat. When they gave the rat DDAVP, or gave him vasopressin, cyst developed. So therefore, it's the water, stupid. So I'm going to be kind of a naysayer and saying, is it tolvaptan or is it the aquaretic effects? Can we achieve exactly the same results with the tolvaptan trial with a water intake that mimicked the water input and output in the tolvaptan trial? So there is one trial going on in Australia, and we're organizing a second trial here that I wanted to call it's a water stupid trial, because we wanted to give, is there anything about tolvaptan that's beneficial to this cyst growth outside of its aquaretic effects, outside you peeing your brains out? Can I do that, I say, by drinking water alone to that same degree? And what we do now is I give patients dipsticks and specific gravity, when their specific gravity has to be below 10.005, which is hypoosmolar urine, showing, and it's very similar to the values that Vince showed up there. If you can keep your urine hypoosmolar by drinking water progressively throughout the course of the day, I believe the hypothesis is that you can achieve the same things you do with tolvaptan by drinking water, and that's just regular tap water. So it's a hell of a lot cheaper than the cost of tolvaptan, and Vince will tell you that, and that's out there. So that's going to be a major impediment to the use of tolvaptan, is the very, very, very high cost of the drug that may not be covered by many insurance plans, or if they are, there's going to be an incredibly high copay. First I heard of right now is between $500 to $600 a month copay. But that was just one so far in Boston. So anyway, so I will turn to Vince and ask my dearest colleague who taught me so much about this. Can we achieve the same thing with water intake alone that we did with tolvaptan?
And my answer is I don't know.
That makes sense.
And I don't think I would dare to be dogmatic about it until you have a proper trial comparing the tolvaptan and increased water. What I know is that it's not the same. I know it's very difficult to suppress vasopressin continuously over 24 hours. I know that the trial, although it was not really a very well done trial by Higashihara in Japan, actually didn't show any benefit of drinking water. but it was not a very good trial. It was had a lot of flaws. So the answer is I don't know, and I think that's maybe something that should be tried. But I don't think I would rapidly go to the conclusion that because I have the assumption that drinking more water will be equally beneficial to tolvaptan, that I would accept that a priori. I think you have to prove it to be able to say, yes, it's true. Now what we have is that we have some good results with tolvaptan. Whether we have the same result with just drinking water, I don't know. I think in terms of the cost of tolvaptan, yeah, I think the cost of tolvaptan is very high. However, we don't know what happens with this is always a negotiation between pharma and the insurance companies. I don't know what will happen with this. I know that Otsuka has, at least in their press release, they indicated that they were going to guarantee out-of-pocket cost for the patient that is actually very low. Whether that is the case or not, I don't know either, but hopefully it will be.
All right.
Just the published price, and I'm not quoting anything yet, is in public. The wholesale cost of tolvaptan, $1,341 per month. Quoted wholesale price, quoted right now. That's in print, so I'm not saying anything out. That's not a secret.
Well, President Trump has said he's going to address the high cost of drugs, so maybe that's going to be a good initiative. I did hear the testimonies from some patients that are drinking a lot of water that are on long-term tolvaptan at our national patient meeting just about a few weeks ago. And what was interesting to me was to hear from very well-informed people how the quality of water does matter, because they're on the tolvaptan twice a day, they're getting up at night, they've been on this drug for many years. They seem to be able to live with it and maintain their quality of life and not be totally fatigued by the disruption that there has to be to some level. And they talked about the use of distillation units in your home and bottled water and lemon flavor of water, and this increases the tolerability of the drinking. So for those patients that are planning to, everybody knows they can drink water for free. If they're planning to do that, the type of water may in fact in the future be something important that we'll be talking about more.
I think one thing that I have been, we have had patients taking tolvaptan for 12 years now, and one thing that actually I'm surprised is how well the patients are tolerating drinking the water and the aquaresis. So they do get adjusted to it. I don't think that is a major issue. There are other issues with the drug, but I think this one, once they go beyond the first few weeks, it takes a while to adapt to it. But once it goes beyond the first few weeks, they adapt to a polyuria of 5 to 6 liters a day. Actually, surprisingly quite well for me. I have to confess that I hate water. So it would be very difficult for me to drink 4 liters of water a day, I can tell you for sure.
So
more work is going to be coming out from some other centers in North America on the tolerability and the aquaresis as well, that suggests that it's quite tolerable, and those are patients.
It's interesting. In our stone, since I run the metabolic stone unit also in our hospital, so I take care of a lot of stone patients, not just in PKD. And it's amazing, if you've had a stone, and women who've had a stone say, I'd rather have a childbirth than a stone. So it's severe. Once someone has had a stone, and if anyone here has ever had a stone, I can tell you, you can drink a lot of water knowing the Grim Reaper that's facing you with pain. So you can build water intake into your system routinely if you know the downside consequences of not drinking water. And it's very common for my chronic stone population, when we monitor their urine, their output, for them to put out 3 to 4 liters a day and have them realize that they're stone free. So for patients who are facing PKD and no family members who've gone through it and watched their parents and their siblings be on dialysis, transplantation, expire, that's one hell of an incentive rather than just telling someone, a routine person, to drink water. So there's no free lunch. We pay the piper someplace along the line for something we do or something we don't do. And I just make sure the patient says, well, this patient said, I can't drink that much water. I'm saying perfectly fine. Here are the consequences of not doing that.
Right.
So people can make an informed decision. You just have to make sure that they know all the facts up front, at least to try.
Yeah. All right, Dr. Stein, great. But just one quick thing about drinking water with stones. There are a lot of stoners that don't drink water and they get a stone back. And compliance with water drinking is difficult. I think the difference with tolvaptan might be that they are so thirsty that they have to drink, and that's a different story. But what we'll hear is from a patient. A patient will be here in a few minutes, and they'll talk about their experience on tolvaptan and water. So let's hear from them. Now, but this was a great discussion. You know, we started with kids, and then we got into water, so that's perfect. Dr. Harris, I think this question is for you. Gene therapy. Any comments on that? And where do we stand?
I think gene therapy in the traditional sense of reintroducing the gene into the kidney, especially as PKD1 is a very large gene, it's very complicatedly regulated. I think it's not that straightforward. You've probably heard about gene editing, where you may be able to go in and correct the mutation within the kidney. I think there's being steps to be made to perfect methods of gene editing. I think they're not there yet. There's too many off-target effects. I think, again, the kidney is a pretty difficult organ to target here. We'd want to get into a lot of cells in the kidney to try and correct the defect if we were going to have a significant effect. And we don't know later on in the disease if re-expressing polycystin 1 is really going to be that effective either. I think another area which is taking account of the mutation, which I think we should be considering a little bit more, is taking a leaf out of the cystic fibrosis book. We know that some missense changes might be stabilized by chaperone treatment, such as the delta 508 common mutation in cystic fibrosis. So that might be an option for some patients with missense changes. There's work to try and develop drugs for nonsense read-through, for premature stop mutations. Those have not done well in human trials yet, but again, that's an area where I think we could theoretically imagine that it could be successful. And I think ADPKD is worth thinking about in these areas, because I think if we could upregulate the level of functional polycystin 1 by 10 or 20%, that might be quite effective in slowing down the progression of the patient. So I think traditional or even new age gene therapy right now is some way off, but I think thinking about therapies more geared to the particular mutation is something that we should be thinking about.
Great. Thank you so much, Dr. Harris. A couple more questions, and I'll just ask Christina to come to the stage. UTIs and cyst infections. And we'll throw in, Dr. Hogan spoke about liver infections too. So what recommendations do you give to your patient about cyst infections and UTIs?
Well, that's a difficult one. So women are more at risk for getting urinary tract infections. People that have stones can run into difficulties with urinary tract infections and get a pyelonephritis or just get an infected cyst by ascending infection. After sexual intercourse, it's important for hygiene in women to prevent infection. Maintaining a high urine output, that is drinking a lot. But hygiene after sexual intercourse is very important. For people that have very recurring infections, they may benefit from some antibiotic prophylaxis. Cyst infection can be quite a severe thing, and at our center we're able to same day usually get the cyst aspirated and drained. The infections that occur, kidney infections that occur, so generally you can make a diagnosis of a urinary tract infection by burning, stinging, passing urine, urinary frequency, and flank pain and fever. So if you have those symptoms, it's important to quickly move ahead with treatment. And in general, the treatment we would go with usually is a quinolone, or depending on your center's sensitivities. But most infections, the majority of infections, as in other situations, are E. coli, and so you want to take an antibiotic that has good gram-negative coverage. Now, another issue is that the current kind of guidelines talk about 3 days of antibiotics. Well, that will not suffice if you have pyelonephritis or if you have a complicated urine infection, like if you have an infected cyst or pyelonephritis, you may need much longer than that. If you're bacteremic, you need usually IV antibiotics at least to start with, and then conversion over to oral. And so we usually have input from our infectious disease colleagues. Other things I would advise would be patients like to take cranberry capsules. There's some evidence for that for prophylaxis. Cranberry juice has got a lot of sugar in it and can lead to weight gain for prophylaxis. Antibiotic, if a patient is having frequent recurrent infections, I may give them a backup prescription. So that prescription then will be good for a year. So again, they can avoid the delay with me getting back to them. And if they develop the urinary symptoms, we can get them on antibiotics right away. It's important to quickly move in on a urine infection. If our patients are going for surgery, if our PKD patients are having a surgery and a urinary catheter is put in, that can be a disaster. They can quickly get a urinary tract infection. That's a very common thing to happen, so to be aware of that. Maintaining high fluid intake, monitoring, sometimes having a follow-up urine culture, and especially if you can get a culture quickly as well, same day, but not to try and delay the antibiotic going with the treatment.
Urine is an excellent culture media. If you want to grow something, you can grow it in urine. So therefore, what you need to do is empty your reservoir. So females, as we know, has been stated before and is well known in the literature, that females with PKD have an increased frequency of urinary tract infections. Yeah. In addition to what Marie said, I have patients void by the clock, not by urge. Empty their reservoir, empty their culture media about every 2 hours. You don't have to set the clock, but generally about every 2 hours you should void by the clock rather than by urge. Empty the bladder. Obviously, voiding post-intercourse is extremely important. You want to empty the reservoir because of that. In addition, for people who have recurrent urinary tract infections also grow very well in an alkaline media. And when is the vagina most alkaline? At the end of menstruation. So therefore, if for people with recurrent urinary tract infections, I have them use a dilute vinegar douche. What's vinegar? It's acetic acid. A dilute vinegar douche done at the end of menstruation can acidify the vaginal mucosa and suppress bacterial growth. And therefore, that's, again, all these are little additional steps. So the urine output, increasing the voiding by the clock, the dilute vinegar douche, frequency, voiding post-intercourse, those are the things that can really decrease the frequency. Not going to cure things, but you can unequivocally, with simple, low-hanging fruit type of modalities, decrease the recurrence of urinary tract infections. And then what Marie said, that for people who have recurrent infections, I then sometimes give them a Bactrim or any other nitrofurantoin post-intercourse. One pill at that point in time for the person with recurrent urinary tract infections can sometimes be very helpful in suppressing the growth of organisms.
One more comment. Older patients that are post-kidney transplant can start running into urine infections, and it's a problem because the kidney transplant's down in the pelvis and it's free refluxing the urine. And so if the patient's bladder is not working, so we need to screen. We screen, have a good look at that, make sure the patient's emptying their bladder. You can get an ultrasound. It's very simple. But if they're not, then some patients do need older men with prostate issues, prostatitis and urine infection. It's a warning sign that the bladder's not working and may need urology or self-intermittent catheterization.
Great. Thank you so much. I think that's all, but just to recap some key things. One is cyst infection and the antibiotic penetration is important. Longer duration of treatment, normally. And the fact that you give them antibiotics to take just in case you have an infection, they can start taking
That's for
it.
the people with recurrent
Correct.
infections. It's not routine. It's for those individuals who are still having a lot of recurrent infections.
Right.
So again, it's trying to use reasonable judgment when you jump and when you sit tight.
Very good.
People, they have funny jobs. They don't have access to bathrooms. I had one guy, he's on the helicopter, so he has to hold on all day because he can't go to the bathroom. So you take a good history, figure out what's going on.
The other thing too, is not uncommon, especially as we age, sometimes you avoid, you maybe not have completely empty, but wait a minute, wait a few seconds, wait a minute or 30 seconds, and try avoiding emptying your bladder again. If you have recurrent infections, especially the female, try a Corday maneuver. The gynecologist will tell you what a Corday maneuver is. While I'm sitting on the toilet, you press just above the bladder, press in and press down. You can expel and flash a little bit of urine. But maybe, again, these are little helpful things. To try a
Very
Corday
helpful.
maneuver as well as everything else.
Awesome. Thank you so much, Dr. Steinman. So thank you, the whole panel, and you can just sit over here. Just a round of applause for our panel.